Welcome to this month's AO Trauma Journal Club. Thanks for joining us. I'm Lauren Tapman, and I'll be one of the moderators tonight, along with my colleague, Jeff Potter. And our topic this evening is humeral shaft fractures. So faculty disclosures are all listed. No conflicts of interest are related to the material that will be presented. Following the webinar, participants should be able to interpret historical results for functional bracing of the humeral shaft and compare that with more recent evidence, evaluate the non-union risk associated with these fractures, and be able to counsel patients on expected functional outcomes after treatment with a functional brace compared to ORAF. We'll go through 4 author interviews, and we'll leave about a half hour at the end to discuss questions from any of the participants. Everyone's microphone has been muted, but please submit questions for the authors in the Q&A section at any time during the webinar, and we will go through those questions following the interviews. All right, I am with Dr. Zeich here, talking about his article, Functional Bracing for the Treatment of Fractures of the Humeral Diaphysis. Can you start off with talking a little bit about what led to the development of this study and kind of where you were at in training at the time?
Yes. Dr. Sarmiento was my chairman when I began the orthopedic residency at the University of Miami for 2 years. And then he was recruited to University of Southern California, LA County. So I worked with him for 2 years as a resident. And I actually did 6 months of clerkships prior to being selected for the residency at Miami. So I worked with him also during that time period. But I was a full-time member of the faculty since 1980.
And can you talk a little bit about the main findings from the study?
Well, the main findings were that we discovered that the functional treatment of humeral shaft fractures was very effective. We had a relatively low non-union rate. There were anatomical changes that were present in some patients, and that's been detailed in the article. So often the anatomy can be preserved fairly well. Sometimes, particularly in arms that are very obese or in people who are very muscular, they tend to keep a deformity of the humeral shaft, yet they still achieve healing. So we wanted to study our experience at Miami and Dr. Sarmiento's experience at USC, combine them to see if our statistics were similar, since we basically were treating the urban trauma population in both locations. And we discovered that if you follow the patients very closely, that this could be a very effective treatment for isolated humeral shaft fractures.
Union rates you all had in the study, 97%. More recent studies, we really haven't been able to reproduce that. Do you think the patients are changed? How surgeons are treating patients has changed? We're doing it wrong? You know, just comments on that.
Yes. Well, as I said, we follow the patients very closely in a special fracture clinic every Thursday. We didn't see them every week, but we did see them very often. And we had a certain protocol that we followed. This was developed by Dr. Sarmiento and some of the faculty staff, whereby patients would be initially immobilized in either a coaptation splint or sometimes a long arm cast. And then at approximately 2 weeks, they would be switched to a humeral fracture brace. Later on, we discovered that in a certain number of patients, you could just put them directly into a humeral brace, and they did very well. But that was our initial protocol. And then they would maintain an arm sling for 2 weeks, but we would encourage them at all times to actively move their hand and fingers to help resolve the edema that you would have inevitably after a humeral shaft fracture. Once they were transferred into the brace, we then permitted them to have gravity-dependent positioning of the arm and encouraged them to actively flex the elbow. So we activated the biceps muscle. The triceps muscle was basically activated by the fact it was an antagonist to the biceps, and gravity alignment of the arm actually helped maintain the reduction or achieve a reduction to some extent. Then They were followed roughly every month with radiographs, sometimes sooner, depending if they didn't fully understand the functional treatment that we instituted for them. And basically, we followed them out as long as we possibly could in this urban trauma population.
In your current practice and over the years, are most of these people getting at least initial non-operative management, or who all are you treating with surgery early on? And how are you counseling them?
Okay, well, for isolated humeral shaft fractures, we still think non-operative management is indicated, and we continue to treat them with the humeral fracture brace. We don't do this for multiple trauma patients. We don't do this for patients that are considered non-compliant. We certainly don't do it for patients who have both upper and lower extremity injuries, or if they have ipsilateral upper extremity injuries, then we think that's an indication for surgery.
When is it most common throughout their treatment course, if you start with non-operative management, are you switching to surgery?
It's more based on the radiographic findings and how the patient's doing.
Yeah.
If they're really having a very difficult time with mobilizing their upper extremity, then we might consider operative management at that point. If we see that there's absolutely no healing in a progressive manner, then that's probably another indication to go to surgical management.
Any comments on some of the more common mistakes surgeons are making when they're trying to treat patients non-operatively and having issues?
Yes, I think the first point is that the patients must use an arm sling for the first 2 weeks. They have significant edema in the entire upper extremity. And if you let the extremity hang down in a dependent position, it goes into the hand, and then they end up with stiff fingers and stiff wrists. So we really need to emphasize the use of an arm sling for 2 weeks. After that, if the patient is put into a humeral fracture brace, they really need to understand the correct application of the brace. There's only one way that the brace goes on the arm, and it's very important to initiate that functional treatment like I talked about previously, where we now start to activate all the muscles of the extremity to actually aid, I think, in the secondary callus that forms.
Any adjustments looking back at this study that you all would have made in the design?
Yes, I would say we tried some changes. For example, we thought maybe in the more proximal third shaft fractures that we would put a sleeve or a almost looks like a part of a shoulder pad over the shoulder in an effort to maintain the reduction better. But we discovered that that had no effect whatsoever on maintaining reduction. And in fact, it led to more stiffness in the shoulder. So we abandoned that idea. The other thing is that it may not be necessarily wise to put a patient in a coaptation splint if they have minimal swelling, they're not terribly painful. You can apply a humeral fracture brace immediately, and actually they're quite comfortable in the brace in addition to the arm sling.
Any of these patients that have had soft tissue problems and wounds that develop in the Sarmiento, or do you feel like that can really be avoided with the close follow-up that you're performing?
I think so, but we also emphasized that they needed to have clean stockinette under the brace at all times and to make sure that it extended beyond the edges of the brace. And a lot of this has to do with the proper wear of the brace. It's a relatively demanding technique, but the results I think can be very gratifying in the correct patient.
Well, thanks so much for joining me today, and we appreciate your contributions to the field.
Okay, today we're joined by Dr. Ring, and with Dr. Ring, we're going to be discussing nominally his paper, Treatment of Diaphyseal Fractures of the Humerus using a functional brace. But one of the reasons we wanted to speak to Dr. Ring was because of his body of work at the time that looked at the treatment of diaphyseal humeral shaft fractures. So thanks for joining us.
Thanks for having me.
I was hoping you could start by elaborating on the state of humerus shaft fracture treatment at the time and describe some of the factors that were influencing your decision to do this research.
Yeah, as I look at these papers, it reminds me of the context. And the context more or less was I was taught, and I'll say taught by the papers that Sarmiento had published and was publishing, and Jesse Jupiter, my mentor, and others, that humeral diaphyseal fracture was generally a non-operative injury, and there was, and I learned some of the particulars of bracing. Not that the brace had to be a certain size or shape, but that it actually didn't need to cover the whole fracture. Like it could end above the antecubital fossa like it had to for a distal third fracture. That's not a problem. Also that it could cause skin problems, that sweating was an issue, that people will feel the bone moving around and they'll hate it for a long time. And yet the success rate is high. And so I was treating the vast majority of them non-operatively, and they're not a common fracture. So it takes a little while to get experience. As I was doing this work, we were simultaneously, there's a whole bunch of other papers where I was writing up Jesse Jupiter's work on non-unions. So there was, a lot of them occur in older people with osteoporosis, which made people not want to operate on it or made the surgeries turn out poorly. And so there's a whole evolution of fixation for osteoporotic bone, getting the screws to lock, blades, large screws, enhancement with sutures, cement, strut grafts, anything you could do to try to get the fixation to hold. And when we were writing up those non-union series, and some of them along with David Helfet, what we noticed is a lot of those non-unions were proximal third oblique fractures. So after I had enough cases to make a decent series, because I'd seen it in my practice, and add to that the whole idea, and I'll call it a bias, sort of a cognitive bias. I'm very interested in that now. It's like how the mind processes these things. And people look at a distal third diaphyseal humerus fracture and they think that won't heal in a brace. But that's the one that always heals in a brace. And I notice I use the word always. I know how dangerous that is to say always or never. But anyone watching this, if you have a non-operatively treated distal third diaphyseal humerus fracture that doesn't have something strange, because I've made this offer a lot and people send me pathological fractures or Charcot or whatever. No, send me a straightforward non-union. I need to see it because I haven't seen it yet. All of the non-unions we've seen are weird stuff and usually misoperative treated. So that's the one that actually heals, and it probably would heal without a brace. But the proximal third oblique definitely have a non-union rate, and it's somewhere around 25%, which is higher than clavicle. But if it's healed or not around 4 weeks. If it's still moving at 4 weeks, it's not going to heal. And we had a lot of trouble with that around this time when we were putting these in for peer review. People said the definition of non-union is 6 months, but that's just torture making somebody wait. On the other hand, it's reasonable to wait 4 weeks, 75% chance of healing, doesn't heal, you go in and operate. And that seems to be a pretty foolproof algorithm in my mind. Is natural healing is great, except for proximal third oblique. And then we added in the distracted fractures later on. More recent study was to look at the ones that are like have a half a centimeter or centimeter gap. Those are, you got to watch those closely. Those don't always heal, but you'll know within a month, and then you can operate. And it's not much harder to operate in a month compared to right away. So that's sort of what I do.
Yeah, it seems like that 4-week statement was pretty prescient because, and I think you hedged your bets a little bit in the study. You said if there's still clinical evidence of fracture site motion after 2 months, that it wasn't going to go on to heal. And
yeah, I've brought it up to about a month.
Yeah.
But if you're not sure, then just wait another month. Like if it might be getting sticky and it looks okay on the radiographs, keep waiting.
So were you doing that at the time?
Well, the way that this happens is, the patient says, "I'm miserable," or something like that, and you look at the X-ray and you go, "I don't know if that's healing or not." What you'd like to see is it's somewhere around 4 months for a shaft or for mid shaft or proximal third where they can start to bend their elbow. It takes about 6 weeks to get there with a distal third. Uh, and that's where you can argue for operative treatment, because you can move your arm right away, more or less, if you can put up with the surgery pain. But if you'd like to avoid surgery, you can. You just got to put up with that in most cases. So it usually comes from either worrying about the X-rays or worrying about the inability to bend the elbow. It takes a little bit longer to abduct your shoulder compared to a proximal humerus fracture, which is usually around a month. So, but if you are worried about it, just take the brace off and just grab the arm and see if it's still floppy. And if it's not floppy, then regardless of what the X-ray shows and regardless of how the patient's complaining, you're probably doing okay. There's some biological attempt to heal that. So just hold steady.
And then, despite this higher rate of non-union, uh, you summarized still advocating for brace treatment as the first line of care. Do you think that's still the case?
Yeah. So this gets into who decides, right? So you're asking me, do I tell the patient what to do? Never. What I do as I help them make a choice, and I feel and I'm going to paint this in stark terms relative to what we usually say. It's an ethical mandate. I'm ethically obligated to make sure that they're not deciding based on misconceptions. That they feel like because it's painful, it needs to have surgery. Because the X-ray shows the bones are apart, it needs to have surgery. Because they can feel the bones moving, it needs to have surgery. Simply because it's broken, it needs to have surgery. Those are all very common misconceptions, and they're not, you know, it's not stupid to think that. It's smart to think that, but it's wrong. So it's a cognitive bias or cognitive error. And those misconceptions are like natural. You should expect your patient to have at least one misconception. Usually they have more than one. And if you allow them to choose based on that misconception, then you are doing them a disservice.
Do you think that if you redid these studies now with dash scores, et cetera, do you think that you would have documented much of a difference?
No, you know, that's been my career for the last 20 years, is showing what patient-reported outcome measure, and they measure mental and social health. They don't measure pathology very well. Um, you can have a trashed knee and a great KOOS score as long as you have good social support. You're not too despairing, and you're not too worried, and you aren't prone to a lot of misconceptions about your pain. So I don't think it adds much. So I think in this case, if your radial nerve works, your bone is healed, your shoulder and elbow are going to work perfectly. So it's the only reason that they'd get stiff is if had some other issue. So your motion comes right back when the humerus heals, and as long as you don't muck anything up permanently by putting the plate on, they're going to have a great arm. Cut muscle and all that stuff, like, it's not normal, but it's a good arm.
Do you think that the that humerus shaft fractures, do you think that's an answered question?
Yes, yeah, I think it is. The newest thing is the newest things are early operative treatment. That's a choice. It's definitely a choice, but it's not a right or wrong answer. Like, if I see a randomized trial and it says the union rate is higher and people get their motion back sooner, I'm going to say, you just proved the obvious. You just proved the obvious. That doesn't help me or my patient decide. You're looking for a winner. Stop doing that. It's not about the winner. And then the other thing is minimally invasive plating. Same thing. It's like, how big of a scar do you want? How much risk do you want to take? Those are already, that's just ask your patient. Just ask them.
So if you encounter this right now, like a distal third diaphyseal fracture, what percent would you say that you're operating on after having that discussion with your patient?
If I am patient enough to make sure that that all their misconceptions are corrected, very few people choose surgery.
And then proximal third, with the knowledge that there's a higher rate of non-union, does that change your initial management, or you just have a threshold to change treatment sooner?
So, if I tell people there's 1 in 4 chance that this won't heal, but we'll know in a month, they usually are willing to wait that month.
And then when you treat them, are you treating them as non-unions, or are you treating them as fresh fractures?
Fresh fractures, humerus fractures don't really need graft. You just need to remind the bone that it's fractured. So you got to drill it open, and you got to rondure the ends, and then you got to get good biologically sound and mechanically sound fixation, and they'll heal.
Anything that you would change if you were doing these studies today?
No, you know, they're really just sort of snapshots, right? And that's all they can ever be. So it's not high level science. It's like an extended anecdote, right? That series of patients, case comparative cohort case series. And I don't think the evidence needs to be better than that. I don't think it can be better than that.
Anything else you want to add?
No, I think we got through it.
All right.
Got through pretty comprehensive humeral shaft discussion.
Today we're joined by Dr. Lasse Ramo from Finland, and we're going to be speaking to him about the study that he led that was published in JAMA earlier this year, and the title of that being Effective Surgery versus Functional Bracing on Functional Outcome Among Patients with Closed Displaced Humeral Shaft Fractures. Hi, Lasse.
Hi,
Thanks for joining us.
thanks for asking me.
So I was hoping you could start by telling us why you think it was time to do this study specifically.
If we go back to Sarmiento's paper on 2002 about the humeral shaft fractures treated with the brace and 98% healed, it was kind of something that raised our eyebrows, since we hadn't seen that kind of success in our unit. And basically other papers after that have had also not so great success with conservative treatment. And even though it's quite a common fracture, we looked at the literature and didn't find any good comparative studies. This was 2010 when I came to this unit, and I had a good discussion with my boss after a year when I was a resident here, and we decided that we had to do something about this and decided to do a randomized control trial on these patients. And also, these were the patients we quite often had long discussions how to treat this fracture.
This is an interesting question to me, the surgery versus non-surgery, because it's something that's not necessarily driven by data from the literature, but a little bit driven by surgeon behavior. And you guys mentioned that in your introduction, that despite a lack of high quality clinical evidence, the surgical rate continues to go up.
There are a few papers on this subject, and we've seen a raise in the numbers of surgeries in the States, in the Netherlands, and in Finland as well. Three papers we found about this. It's time to have some evidence to support this trend.
And what do you think is driving that in the lack of high quality evidence, that increasing surgical rate? Do you think that we're, as clinicians, just seeing a higher non-union rate than is in the literature? Is it difficult to watch patients suffer through the first, few weeks of non-operative treatment? What do you think is really driving that?
That's a good question. It's something that the patients might want a little bit more nowadays than they used to do, let's say 20, 40 years ago. So they demand more and quicker recovery, and that might be one reason why some surgeons prefer surgery. We might think that the patients get well quicker if we operate on them, and that might be one reason. And then also I would say cultural things. We think that we've developed as surgeons, and we think that we have better results with modern techniques compared to old school non-op treatment. So those might be the reasons behind these trends we've seen.
Now might be a good chance for you to just refamiliarize us with what your primary outcome measure was for this study and what your findings were.
Yeah, so our primary outcome was DASH, disabilities of arm, shoulder, and hand at 12 months after the fracture, so after the randomization, basically. And our primary outcome was that there was no statistically or clinically significant difference between the patient groups between surgery and functional bracing at 1 year. So it was 8.9 points in the surgery group and 12 points in the bracing group in intention to treat analysis. Yeah.
If we could chat about this figure for a minute. In the body of the text, you elaborate on the 1 year DASH scores and how there's no significant difference.
Yeah.
But at 6 weeks, at 3 months, there was a significant difference with clinically important difference. And at 6 months, it was still close to a clinically important difference between the two groups. Some people, I think, might argue that that there's an argument to be made for surgical treatment in that 6 month window where people are doing better.
So basically the problem is that if you have several time points as an outcome, then you have a multiple comparison situation. And we decided that at 1 year at least, the situation has to be stable, more or less. And that would be the latest that the patient should feel fine after this kind of injury. One might argue that at least or latest at 6 months or even 3 months, the patient should feel fine. But as we can see from this figure, that even the patients with surgery didn't feel fine at that time, since they have higher points or above the MID compared to scores at 1 year. So basically they didn't do fine at that time point, but they did better compared to functional bracing group. And I think this has implications in shared decision making. You can tell your patients that there's a fair chance that you feel better in the early phase of the recovery, but you will still get better during time, and at 1 year you have similar results no matter what the primary treatment was.
And then your definition of non-union, I'm going to read it out, was no bridging in 3 out of 4 cortices at 3 months, plus clinical evidence of fracture site motion. And that's maybe a little bit different than the traditional definition of non-union, but probably more in line with the way of people are thinking about humeral shaft fractures now.
That was a good discussion in our group as well. When should one deem a fracture, a humeral shaft fracture, non-united? And it's a difficult decision to make, but we thought that earliest at 3 months we can offer operation for a patient if the fracture is mobile and we don't see any callus formation, at least on the 3 cortices. So those were simple decisions to see that those that were operated really had a non-union.
Your crossover rate was about 30% with a 25% non-union rate.
Yeah, it was a surprise to us to see that high rate, but then maybe by chance in the early this year we had this paper by Serrano et al. about from the US, and a big retrospective cohort of 9 academic hospitals from the States, and they were just looking at this specific thing, how many patients with functional bracing end up having surgery, and they had a 29% or 30%. So basically just in line with our findings. So it seems that it's quite credible estimation of how many patients end up having surgery if they start with functional bracing.
I thought one of the questions that you asked that was interesting was asking patients how willing they would be to undergo the same treatment, the last line on this table.
Basically, the patients with surgery, they were happy. Basically, those 70% of the patients in the bracing group, they are the ones who healed well. So those who heal well, they are happy. And actually, not all the patients in the surgery group do fine at 1 year. If you go back to the figure, so the outliers are there. So you see that also in the surgery group, there are several patients with very high DASH scores, and still 97% of the patients state that they are willing to repeat the same treatment. So one might argue that people feel that at least they tried, meaning us surgeons, that we tried to help them, but I'm not doing fine, but I would choose again to have this trial of surgery.
Have the results of this study changed your practice?
Nowadays, we tend to give more thorough information to the patients and maybe a little bit higher operation rate. But we looked at our hospital data before this trial, and we found out that actually 50% of the patients with humeral shaft fractures had a primary surgery in our unit from 2006 to 2009. So basically, we've been quite active on operating on these injuries even earlier. But the feeling is that it's gonna be higher after this trial.
We play you guys in hockey, and Finns have a reputation of being pretty tough. And there was only 2 patients that were not tolerating the bracing. Do you think that somewhere where maybe the population isn't as tough, that the crossover rate for not tolerating bracing would be a little bit higher?
Yeah, that's a good question. In Finland, we Finns have this thing called sisu, meaning we have good endurance and tolerate lots of things. So one might argue that you cannot have good external validity for our results. You cannot compare us Finns to other people, but I don't believe that actually. So basically, I think the functional bracing is quite well tolerated if properly advised how to use it. We're not special in that sense here in Finland. In hockey, we are special, but not in humeral shaft fractures.
Anything else that you want to tell us about this before we wrap up?
Yeah, I'm waiting for the results from the Canadian study and from the Edinburgh study as well from the UK. So then I think we have to have another Zoom meeting about meta-analysis.
I think it will be interesting because even if the results are similar to yours, I don't think that it answers in black and white exactly how we should be treating these, other than pointing towards more shared decision making.
Yeah, thanks for pointing that out, because but that's how I think that's how we should approach these problems, that we try to have the best information we can from the studies, and then share this information to our patients, and then make the decision together with them. So life is not black and white, and different patients like more gray, and different patients like more light. So that's we just can give some more information to our patients with these trials.
So I am here with Doctors Eagle and Dreisman. And why don't we just get started with you talking a little bit about what led you to ask this clinical question?
So, it's interesting. It goes back actually to my residency. I trained under a surgeon named Howard Rosen, who is one of the fathers of fracture surgery in America. He was actually the first one to bring the AO back to the United States in the late 1960s. And I remember him telling me, we're talking about humerus fractures, and he was the one who actually told me that, you can tell the fractures that were going to heal by about 6 weeks, that if, there was no gross motion at 6 weeks, then you knew that was one that was going to go on to heal. And if there was still mobility there, then, potentially that was one that would need surgical intervention, because he was very big on humerus non-unions. And, something that just, it was part of my training, was part of, the way I, manage patients when I started in practice. And I did it for years and years. And I always made a note in the patient's chart, at 6 weeks, if there was gross motion at the humeral fracture site. And it was when a resident asked me about it that I started thinking, I'm like, how come he doesn't know this? I thought everybody knows this, And then I went and I looked in the literature and I saw, there's nothing really written about this and there's nothing in a textbook about it. So that was really the impetus for starting the study. And we went and we looked at a consecutive series of patients that I had treated, using this technique, and that's where the data came from. And that's what this, was spurred on. Just like many of my ideas come from questions I get asked by the residents.
And can you guys summarize in a few points some of the main takeaways and findings?
Yeah, sure. So this project was really examined not just the clinical data points that we normally look at when we think about research in non-union therapy, but really investigated the art behind how we treat these non-operatively. And obviously, if you look at a lot of the papers coming out more and more recently, there's more of an impetus to try to operate on these. But we especially see a lot of these fractures in our fracture clinic when we do treat them with a coaptation splint followed by a Sarmiento brace. And our main summary is that when you follow these patients out, you really need to examine not just radiographic findings, but clinical findings, especially at various time points as you move farther and farther away from the original injury. At the 6-week time point, we examined fracture site mobility with a gross motion test. So we stabilized the proximal fragment with our hand, and then the distal fragment, we would shuck both an anterior, posterior, and various valgus forces to see if there's any motion at this site. And if there was any gross motion there, we then noted that those patients, when we looked at it retrospectively, actually had a much higher likelihood of developing a non-union. So this was a retrospective review. It was a consecutive case series looking not just at Dr. Eagle's patients, but all trauma surgeons who are taking care of these fractures at NYU, and looking at the various time points that they are treated postoperatively to see if these patients who have conservative management for humeral shaft fractures, which were predictors of non-union. And we found that gross motion at 6 weeks had the highest likelihood of developing a non-union.
The protocol you used for this study, there's a little bit of variation, but it sounds like they got a coaptation splint. At a week, you put them into a functional brace, and then you saw them at 2 weeks, 4 weeks, 6 weeks, and then again at 3 months. Has this been adjusted at all after your findings?
So I think the most difficult part about treating someone non-operatively with a humeral shaft fracture is the education on the use of the brace. Because if it's not applied properly, and I see this often, sometimes our residents put people into the brace immediately in the ED, and I see a lot of people with skin breakdown and other problems. And then people say, oh, you see the brace, you have all these problems with using the brace and whatever. And it's really because you got to educate the patient because they have to be actively involved. So you have to have someone who has, the wherewithal and the, educational level to understand what to do when you explain that. They have to be actively involved in adjusting the brace, changing the compressive forces by adjusting the Velcro straps daily and making sure it's not digging into the antecubital fossa. So as far as is the protocol the same, essentially, yes. We did another study later on where we looked at radiographically if things changed in those 2-week and 4-week follow-ups. And really, after the functional brace is applied, that's pretty much the reduction. People don't tend to lose any reduction, and things tend not to shift once you reach that point. So it's probably overkill to continually, have people undergo this X-ray examination. So I've adjusted, and I pretty much go now. They're seen in the ED. We put the brace on between 10 days and 2 weeks, and then I see them again at 6 weeks. But if there's any concern, obviously they come back sooner. They're in touch with us. We give them email, and they can catch us through the electronic medical record. So we don't. There's a lot better communication now between us and the patient. So I think we see a lot less of the problems.
Mm-hmm. So some of those visits were patient counseling, but the radiographs may be unnecessary earlier on.
Correct. Sometimes it's about reassurance as well, because people feel very uneasy. They definitely feel the fracture moving. They don't like it. They feel like their arm is disconnected from their body. Sometimes you just have to reassure people. And what's interesting is, I've treated a bunch of upper extremity fractures non-operatively, and I always ask people, if you had to do this again, would you go through the same thing, or would you take an operation on day one and you'd feel better almost immediately, but you would have to undergo surgery? And for things like clavicle and some other fractures, I've had people say, no, I'd rather have the surgery, but I've never had anyone with a humeral shaft say they'd rather have the humeral shaft surgery.
So during this study period, this was 2007 and 2015, 17 of your patients with humeral shaft fractures were treated initially with surgery. Do you think that rate's about the same? Is it higher? Is it lower?
I don't think personally, I can only speak for myself. I don't think my indications for fixing humeral shaft fractures acutely has changed. Obviously, these are all isolated humeral shaft fractures. These are not the humeral shaft fracture that comes in with a femur fracture,
Right.
or the multiply injured patient who can't be nursed sitting up, who has a chest injury, or that's not what we're talking about here. These are in general the low energy humeral shaft fractures, isolated. So for me, I still aim to treat the majority of these non-operatively, regardless of their location, regardless of whether the nerve is in or out. But there's a long discussion that's had, and what's interesting, many times I have to talk people out of surgery because people get sent to me often, by someone outside in the community, and they're sent in because they think that they have a bad fracture that needs an operation, and they're told that they need surgery. So when I tell them, I don't think you need surgery, they're a little bit confused. And that's another long discussion you have to have with people. So, the art of medicine is, knowing how to talk to patients, giving them all the risks and benefits, and understanding what individual patient needs are. For instance, I've had a low energy isolated humeral shaft fracture in a surgeon who I operate on acutely, and they can get back to surgery within a week. That's a different situation from, a college student, for instance. So I would say that my rationale and surgical indications has not changed. But I think all treatment has to be individualized for the patient.
For the general topic of humeral shaft fractures, what do you think still needs to be addressed in future studies?
Well, the strength of this study is that it allows us to look at the kind of art behind how to treat humeral shaft fractures, but it doesn't, as a retrospective study, it doesn't look prospectively at various different protocols and whether can you randomly assign one patient non-operative, assign another person operative treatment, and which one is going to do better. I know Dr. Eagle, when he educates us often about humeral shaft fractures, the indications for trying to get a proper reduction, those were set in the mid-60s based on papers that really just looked at cosmetic differences rather than actually looking at functional differences. So I think further prospective studies really do need to focus on prospective functional outcome scores, looking at the differences between the two. And again, even when patients obtain union for humeral shaft fractures, it's not a benign course, as Dr. Eagle was alluding to. It takes multiple weeks, it is not the easiest healing process. And we really have to be better at assessing how patients are recovering throughout their healing process and if they're really truly happy with whatever outcomes they obtain, whether it's just a clinical cosmetic outcome or if it's actually their true functional outcome, whether they're able to do the activities of their normal living.
And the other thing that really isn't addressed by any of these things are people's functional and personal demands are a lot different nowadays than they were 20, 30 years ago, or, when in my grandparents' time, right? Patients' expectations. So we don't know if fixing someone's humerus shaft and allowing them to return to work within 2 weeks to a desk job or whatever, that they'll be able to get back to much sooner with an operation is a significant benefit to them and to society as compared to, treating them functionally as we've done, taking away all the risks and benefits of the intervention itself. But just what does it mean to be more functional sooner. I don't know that we know the answer to that. And perhaps future studies will address those specific issues.
All right, gentlemen. Well, thank you so much for joining in, and we appreciate your contribution to the field.
Thank you very much, and it's a pleasure to be here. Thanks so much.
Yeah, thank you.
Okay, it looks like we have about 25 minutes here for discussion. We've had a few questions roll in. I'm going to try and get through these, and we'll let the panelists weigh in. We've had a few different questions on specific populations. So the first one that I'd like to ask about is elderly patients. And the question that we have asked specifically about elderly patients who are dependent on their upper extremity for assistive devices for ambulation, and whether or not that changes your treatment protocol. Maybe Dr. Eagle and Dr. Dreisman, you could start us off, and we'll go through the panel.
For me, a isolated humerus shaft fracture in an elderly patient is not, and the need to weight bear is not an indication for surgery. Although I do think with well-aligned fractures, well-reduced fractures that are fixed, they can bear weight immediately. I don't use that personally as an indication. Most of these patients can get around using a cane in one hand. And if they can't, they may end up being wheelchair bound for a short period of time. Usually by 4 to 6 weeks, there's enough stability that they can bear weight through the fracture site. So again, that's my personal opinion. And some of the other panelists may have a different one.
Dr. Ring, you mentioned some of the difficulties in fixing these fractures in elderly individuals.
Yeah, that's a good point. It's not a freebie. And looking up Jesse's series of non-unions, just see screws flying everywhere and plates ripped out and extra fractures below the plate and things. So I think it's all shared decisions, and the way that Ken outlined the extra factors that come into the decision, it's still a shared decision.
Dr. Ramo?
So yeah, I agree with Dr. Ring about this shared decision with these patients. So personally, if the patient needs both hands in ambulating, then I tend to recommend operating on them, but that's always something we discuss together, and sometimes with the relatives of the patients as well, if the patient is not able to make the best decision.
Good point. Dr. Zeit, does patient age and ambulation status change your treatment protocol at all? Dr. Zeit, I think you're still muted.
Sorry. I think I tend to agree with most of the other panelists too. In our experience, osteoporotic bone is a very difficult problem to manage in terms of operative repair. And I don't know that you can really satisfactorily stabilize an osteoporotic humerus in somebody who's really going to put full weight on the arm successfully. So we would tend to try to go with non-operative management first and see if we can get the patient to where they need to be, to the point where possibly they could start walking.
When would you let them put weight on that? Would that be a radiographic decision, a clinical decision, or strictly a time-based decision?
It would depend on clinical exam and the radiographs, I think.
Okay, thanks. And then the other population that's come up is obese patients. Does obesity change your treatment protocol at all?
We believe that we had a relative contraindication to put obese patients in braces, but we treated a number of them, I think very successfully in braces. They tend to have more deformity, anatomic deformity, but this is exactly the type of arm that you can't even notice any angulation in. I would say if they have other reasons to have something done to their body, you know, for example, if they had another fracture that had to be treated operatively, and that there was a question of weight bearing, I think we would tend to probably operate on the humerus then.
Okay, thanks. Anybody else? Different treatment protocol for obese patients?
So when you look at our manuscript, a lot of people focus on the gross motion aspect, but we also looked at other predictors for non-union. And one of them that was an independent variable was obesity. However, when we ran a multivariable logistic regression model, it did not come out to be significant. If I really took away anything from this, I think that when treating humeral shaft fractures, there's very little that are absolute indications. I think it's something that you can discuss with the patient, that they might have a higher likelihood of developing a non-union, and something to keep an eye on if they do decide to treat it non-operatively.
Thank you. We've got a question about degrees of deformity. Any thoughts on what the upper level of degrees of deformity is? Is there a threshold that would cause you to operate?
Deformity just makes your arm look funny, more so if you're skinny, but it doesn't affect your function. So again, it's kind of a shared decision. There was one question in the chat about whether you'd have your own fracture fixed, and we meet, and Ken mentioned a surgeon that he might treat. I actually took care of a medical student who had quite a bit of varus deformity, and he chose non-operative. He healed non-operative and was satisfied with a pretty bent looking arm. So it doesn't affect function, but it can look funny if you've got particularly if you have a skinny arm.
I think
the other thing is, we also did a study, like a computer generated model kind of study, where we created different deformities, and we looked at where you could put the hand in space. And you almost can't ever get a valgus deformity with these. They're almost always varus. And varus is good because varus brings your hand closer to the midline, which is where everything is. So if your deformity was in valgus, I'd be more concerned about that, but I've never seen that in clinical practice. So a varus deformity doesn't bother me. I don't care how big it is. It's not the number. You got to just tell the patient that it's going to look like that on x-ray, but when you look at them clinically, you're almost not going to see anything. As long as they have a normal arm, if they're really, really thin, you'll see a little bit of a bump there, but otherwise you're not going to see much.
I almost feel like we should have had this in the disclosures. The question that one of the attendees is asked, who on the panel, if you had a humeral shaft fracture, would have it treated with a brace versus open reduction internal fixation?
I'm going to go with functional brace.
I probably have some resident operate on me and knock out my radial nerve.
I would go with the functional brace.
Dr. Ring?
Well, yeah, I'd go with a brace, but I just pointed to some studies we did where we gave this question to a bunch of surgeons, and we did it a couple different ways. One, we had them do personality tests, and their personality determined it. Another one, we randomized them to imagine the patient was them, like it's you deciding for yourself. And the other randomization was someone similar to their age and same sex, and that was they were more likely to choose surgery for somebody other than themselves. So we measured the surgical double standard.
Dr. Ramo?
Yeah, I think I would like to have my fracture fixed by one of my colleagues from the upper extremity unit. So maybe not the residents, but specialist.
Yeah, I think the same, as long as somebody's comfortable around the radial nerve. Dr. Zeit, could you elaborate on the treatment of gunshot wounds in fracture bracing?
Sure. Basically, the gunshot wound has a wound on the arm, but basically the vast majority of them are low velocity injuries, so there's minimal soft tissue damage. And we basically treat them just like we would a closed humerus fracture. Initially, we'll give them a short course of antibiotics, but in our experience, they heal as do a regular closed humeral shaft.
Yeah, I'll chime in on that. The distal third diaphyseal humerus fractures, people say the brace is not distal enough, and they always heal. Gunshot fractures do fantastically in braces. And then the last person I treated in a brace was a pandemic treatment. I think I saw the guy in the office once. It was mostly virtually, but he broke his shaft basically from stem to stern.
Wow.
And fragmented, spiraled. One part was displaced, healed it up beautifully in a brace. He was miserable for the first 3 weeks, but healed it up. It would have been a really, really difficult surgery. He also had a pretty bad bone quality. So I think it's a little bit those are those counterintuitive aspects. And the thing that Sarmiento did is that they wouldn't even take him to the OR to breathe the wound. They just kind of washed out and put him in a brace. Isn't that right, Greg?
It depended on the attending involved. I would say for the most part, we at least just gave him antibiotics and just dressed the wound. That's true.
Good. There's been a few different questions about other treatment methods. Does anyone see a role for hanging arm cast, humeral shaft fractures?
Yeah, Paul Tornetta still does that in Boston. So when we were there, we combined our series, and it's about the same result. I think somebody was asking about elbow stiffness. The amazing thing, if there's not an injury in the joint, then like if you have a distal biceps rupture and you're in a cast for a month, your elbow doesn't get stiff. If you break your radial head and you're in a cast for a month, your elbow gets stiff. So humerus is outside the shoulder and the elbow joint. So even if you're not moving your elbow for a couple months or shoulder for a couple months, you'll get the motion back.
Anyone else see a role for hanging cast?
Yeah, we had a negative experience in Miami with the hanging arm cast, but I think that was just our patient population. But we saw a unacceptable amount of distraction at the fracture site from the cast. And I think it was mainly not understanding how the hanging arm cast should work, and also trying to put as much plaster on the arm as they possibly could to immobilize the fracture.
Regarding bracing, I'm sure you guys can comment, but I've had people come in with the brace around their elbow, around their shoulder, gone in a bag, and the bone still heals. I'm not entirely sure the brace is doing a whole lot. What do you guys think?
Well, I think what it does is it gives appropriate receptive feedback to the patient. And so I think it really enhances their ability to use the arm functionally while the fracture is healing. That's my take on it. But many, many years ago, there was a fellow in the Scandinavian journal called Spock, and all he did was treat the patients with a canvas sling around the neck and then put this around the hand. And that was his treatment for humeral shaft fractures. And he reported a high success rate, even just with that. So I totally agree. Nothing magical about the brace. It's the functional treatment that really makes the difference.
And I think someone else mentioned it, but the deltoid extension, is that necessary or not necessary for proximal third?
We found it made no difference whatsoever, and I agree with Dave that the proximal third humeral fractures are problematic, and particularly if the fracture is oblique and the deltoid insertion is on that proximal fragment, you get a constant abduction force away. And so the arm goes down and then the shoulder goes up like this. And so that tends to, I think, induce a greater chance of fracture not healing. So, but we didn't find that the extension over the shoulder did anything, even though today you still see some people using it.
And Dr. Ramo, you guys had a very good diagram illustration of that in your study and excluded those patients for that reason.
Yeah, that's correct. So in our unit, we tend to operate on these type of injuries, as our experience on them is that they so often go to non-union, and some of the patients have the bone coming out through the lateral part of the arm. So we if the patient is operable, we tend to offer surgery for them. So we excluded those patients from our trial.
Dr. Driesman, we've had somebody ask how painful it is to stress these patients in clinic at 6 weeks.
I think the patients are just a little bit more surprised to actually have us do it. When you actually stress it, I find that they tend to actually not be in as much pain, unless, especially if it's healing properly.
Good. I mean, I guess that's part of your clinical indication. If it's painful, that's going to point you in a certain direction.
Yeah.
So you guys did 6 weeks. Dr. Ring, you've mentioned 4 weeks. When is everybody pulling the trigger on operating on these?
I would say that if it's floppy at 4 weeks, like if you're not sure, I wouldn't pull the trigger. But if it's flopping all over the place, it's not going to heal.
Dr. Zeik, you're nodding your head.
Yeah, I think what we do is we tend to follow the patient clinically, and fracture site motion by itself is probably not a big factor if the patient is reasonably comfortable. If they have a lot of pain when you manipulate the fracture, then that tends to drive us more to consideration of the fracture not healing and then considering operative management.
Dr. Eagle?
Yeah. To me, if there's no motion at 6 weeks, they're not in pain. They're comfortable. Most people, even if they have motion, are pretty comfortable by 6 weeks. You know, I have very few people who have painful humerus non-unions. I have a lot of people who present to me with, diminished function non-unions in the upper extremity. They end up, in fact, Howard Rosen, as I mentioned his name again, had a big series of patients that he liked to call the painless non-union. And these were mainly in low demand elderly people that would end up with a, mid-shaft humeral non-union, and they'd lift up their arm and it would go floppy. And he would tell them, you see, you've got an extra joint. Pretty soon, everybody's going to want one.
And then when you do treat these, who's treating them as fresh fractures? Who's treating them as non-unions? Is anybody bone grafting them? Does it depend on how far out from their injury?
I'll just mention that even though at 6 weeks, I'll be able to determine that someone's not going to heal, I'll still give people up to 3 months to see if they will heal. I don't pull the trigger at 6 weeks and say, okay, you should have surgery now. I still wait, but I will tell them that my suspicion that this is not going to heal is very high. So by the time I get to them, it's usually 3-4 months down the road, and I'll add something biologic. I'll usually probably add a little bit of autogenous bone graft, depending, is it an atrophic non-union or a hypertrophic non-union. But when you operate on these, there's a lot of stripping that goes on to get these things lined up, to clean out the non-union site in order to drill the canal proximally and distally. You do a lot of stripping. So I think that you've damaged the biology a bit, and I like to add biology when I do this surgery. So if I do a non-union of the humerus, I'll almost 100% of the time do an autogenous iliac crest bone graft as well.
Don't they think you're a little crazy if you tell them at 6 weeks that it's not going to heal, and then you tell them that you're just going to wait for another 6 weeks or another few months?
Well, those are true, and maybe not related, right? I might be crazy, but there's still a chance. It's not 100% that if there's a motion at 6 weeks that it's going to go into a non-union. There are still some people that will go on to heal, and there are some people who don't, they don't want surgery. So you give them a little bit more time. You have to let it kind of sink in that they're going to need it. I'm not one to push people. Now, if I have someone at 6 weeks, they're like, I don't want to wait anymore, I'll go ahead and do it. There's no problem. But if I'm going down the non-op pathway, I usually will give it at least 3 months. That's just my, my personal preference.
Dr. Zeik, you want to comment on when you're operating and what your preferred procedure is?
Yeah, I think the time element is important to wait. We typically would wait at least 3 months, as Ken said. I think our surgeries are probably more stable internal fixation. If there are any significant gaps that are created at the fracture site, either by us surgically or whether they pre-exist, we probably would use a bone graft as well. We'd use maybe a combination of autogenous bone and some bank bone.
And Dr. Ring, you differ in using bone graft?
Yeah, If you look at Dave Helfet's series, it's like some 80 or 90 non-unions, and he was using demineralized bone matrix, which is like the worst possible graft substitute, I'm told. And then he eventually stopped using it because he figured maybe didn't need it. Yeah, it depends on the fracture. So I won't say I don't strip, but I try not to strip. I try to leave the muscle and the periosteum on. I don't try to get a lag screw. That's actually, I reviewed the Helfet series, and they said they did a lag screw and a plate. I said, you do a lag screw, because by the time you're done debriding the fracture site, and if you're doing it late, and if it's a synovial non-union, it's not really going to take a lag screw very easily. You have to work hard to get a lag screw. And I end up usually just getting everything biologically set, and then getting biologically and mechanically sound fixation. And the humerus seems to want to heal. That's what came out for me. What came out of the Helfet series is that you can use demineralized bone or nothing, and if you do good surgery and get rid of the sclerotic bone in the fracture site and do good enough fixation, it'll heal. And that's been my experience.
Dr. Ramo, anything to add?
Yeah, so I agree with Dr. Ring. So basically, the cases I've done non-unions, I very seldom use any bone substitute. So only do good debridement of the non-union site and then fix it. So I haven't used any, unless there's a big gap. Then I have to consider shortening the humerus or putting some. I take iliac crest then.
Thanks. We've had a few questions. I think this will be the last one about radial nerve injury, whether or not it influences your treatment decision. Part of that, let's start with that.
I would say no. It has no influence on our treatment.
Remember, we were talking about the subset of closed fractures that you could brace, so I would agree.
Okay, and everyone's with, I think we spoke a little bit about, Dr. Ring, you and I spoke about this, but you know, it might change if it was an open injury or gunshot wound and you had a higher chance of a laceration. Might be the only role for.
If you have an open fracture radial nerve palsy, you better go in there and look, because half of them are torn apart. And my other tip would be to use a lateral skin incision, because the person that's going to fix the nerve, like me, is going to be mad if you're in the back and I can't get to the front of the nerve, and they're going to be mad if you're in the front and I can't get to the back of the nerve. So make a lateral skin incision, put the plate on the front of the back, your choice, your lateral skin incision, but I can at least get to the nerve.
Okay, great. I think we're going to have to end it there. Thanks everyone for joining us. Thanks especially the panelists. Thanks to Dr. Ramo. It's 3 or 4 in the morning now in Finland, so he really stretched it for the day to make it to join us. We've got dates here for upcoming journal clubs. If you guys can join us, that'd be great. Thanks everyone for joining.